This is Run the List by Blood and Cancer. In Run the List, we'll bring you the latest in hematology and oncology news from MD Edge and Medscape. The stories in the show have been written and adapted for podcasts and are available in their original form on MD Edge and Medscape. The show notes include links to the stories, the original source material like journal articles and meeting abstracts, and relevant biographical information. I'm the host of Run the List and Blood and Cancer, Nick Andrews. We begin today with what could be a new gold standard for prostate cancer screening. Prostate-specific membrane antigen, PET-CT, was 27% more accurate than conventional imaging for detecting metastases and staging men prior to curative intent therapy for high-risk prostate cancer. This is according to the Phase 3 Pro-PSMA study presented at the 2020 Virtual Congress of the European Association of Urology. These data were also published in The Lancet, and you can find the original Lancet publication in the show notes. Dr. Michael Hoffman is a professor and nuclear medicine physician and scientist at the Peter MacCallum Cancer Centre in Melbourne, Australia. In his presentation, Dr. Hoffman said that he considers these data to be practice-changing. He said that the PSMA PET-CT was strikingly better than conventional CT, saying that pelvic and abdominal mets that are barely visible on CT were lighting up on PSMA PET-CT scans. The study also showed that PSMA was superior to CT and bone scans for picking up metastases throughout the body. Okay, so let's look at the study. Pro-PSMA is a multi-center Phase 3 trial directly comparing PSMA PET-CT scans and standard of imaging. Of 339 men assessed for inclusion across 10 centers in Australia, 302 were eventually randomized. They had a median age of 69 years. All patients had high-risk prostate cancer, which was defined as a prostate-specific antigen level of 20, Gleason grade group 3 to 5, or clinical stage T3 or higher. All patients were about to undergo either surgery or radiotherapy with the intention of curing the cancer. Okay, so what did the researchers find? The researchers report that the accuracy for PSMA was 92% and 65% for CT and bone sonography. When comparing PSMA to CT bone scans, the researchers report that the detection rate for pelvic nodal metastases was 91% for the study group and 59% for the bone scan group. For distant metastases, the PSMA detection rate was 95% and the bone scan detection rate was 74%. Further, PSMA had a greater effect on treatment. First-line imaging led to treatment changes in 28% of the study group and 15% of the CT group. Second-line imaging led to treatment changes in 27% of the study group and just 5% of the bone scan group. Dr. Matthias Heck is a urologist at the Technical University of Munich in Germany. He points out that the study design may have resulted in oversensitivity of PSMA PET-CT scans. He said that as a urologist, he wants to address how the number of histopathologic validation. He pointed out that pelvic lymph node sampling was performed only in 66% of patients treated with radical prostatectomy for high-risk prostate cancer. Hard criteria to define the presence of metastases were only used in 23% of patients with METs. Therefore, it is possible that the sensitivity was overestimated by using mainly soft criteria. The sensitivity of PSMA PET-CT was 85%, while the sensitivity of CT bone scan was 38%. And there are new data suggesting a need for genetic testing for early onset cancer. Patients with early onset cancers have an increased prevalence of germline pathogenic variants. In a presentation at the 2020 AACR virtual meeting part 2, Dr. Sofia Stadler suggested that genetic testing would be worthwhile among these patients. Dr. Stadler is an oncologist at Memorial Sloan Kettering in New York. She and her colleagues analyzed blood samples from 1,201 patients who were aged between 18 and 39 years when they were diagnosed with a solid tumor malignancy. The researchers analyzed 877 patients with early onset cancers and 324 patients who had young adult cancers. Early onset cancers were defined as those for which an age of 39 years is greater than one standard deviation below the average age of diagnosis for the cancer type. Cancers for which 39 years old was less than one standard deviation below the average age of diagnosis were considered young adult cancers. The most common early onset cancers were breast, colorectal, kidney, pancreas, and ovarian. The most common young adult cancers were sarcoma, brain cancer, and testicular cancer. The researchers performed next-generation sequencing of the patient samples using a panel of up to 88 genes that have been previously implicated in cancer predisposition. The sequencing revealed a significantly higher prevalence of germline mutations in patients with early onset cancers than in those with young adult cancers. 21% of early onset cancer patients had a germline mutation compared with 13% of young adult cancers. In patients with only high risk and moderate risk cancer susceptibility genes, the prevalence was 15% with patients with early onset cancers, and it was 10% for young adult cancers. Dr. Stadler pointed out that among the early onset cancer group, pancreas, breast, and kidney cancer patients harbored the highest rates of germline mutations. She said that the spectrum of mutated genes differed in early onset and young adult cancer patients. In early onset patients, the most commonly mutated genes were BRCA1, BRCA2, Lynch syndrome genes, ATM, and CHEK2. For young adult patients, the most common were TP53 and SDHA and SDHB. Dr. Stadler said that the results suggest that among patients with early onset cancer, the increased prevalence of germline mutations supports a rule for genetic testing irrespective of tumor type. And we move now to the impact that early screening could have on breast cancer mortality for childhood cancer survivors. For women who had radiotherapy for a childhood cancer, starting screening in young adulthood could cut breast cancer mortality in half among these patients. This is according to the results of a modeling study published in the Annals of Internal Medicine, and you can, of course, find the link to the original publication in the show notes. Researchers report that two strategies cut breast cancer mortality in half when they were started at the ages of either 25 years old or 30 years old. Those strategies are annual mammography with MRI and MRI alone. Dr. Jennifer Ye is a researcher at Harvard Medical School. In the study, she and her colleagues developed models to compare outcomes with various screening strategies among women who were 20 years old who had received chest radiotherapy for childhood cancer between 1970 and 1986. The women had been diagnosed with Hodgkin lymphoma, non-Hodgkin lymphoma, Wilms tumor, and other various cancers. The investigators conducted their analysis using data from the Childhood Cancer Survivor Study and other published sources, a lifetime horizon, and a payer perspective. The team assessed three strategies. The first strategy was no screening. The second strategy was digital mammography with MRI starting at 25 years of age, 30 years of age, or 35 years. The third strategy was MRI alone, starting at 25, 30, or 35 years of age. The main study results showed that without screening, women who had received chest radiation for childhood cancer had a 10% to 11% lifetime risk of breast cancer mortality across models. Relative to no screening, starting at age 25 years, the largest share of deaths was averted with the strategy of annual mammography with MRI or with a strategy of MRI alone. These two strategies also yielded the most screening tests as well as the most false positive test results and benign biopsy results. The researchers also considered the financial cost of screening. When they compared the costs, they found that 30 years was the preferred starting age for screening because it dropped the incremental cost-effectiveness ratio below the generally accepted threshold of $100,000 per quality-adjusted life year gained. Dr. Ye and her colleagues wrote that screening guidelines should emphasize the importance of MRI screening with or without mammography among survivors. They also wrote that the findings highlighted the importance of ensuring that survivors have access to health insurance coverage for MRI screening. And finally today, delays in cancer referrals caused by the COVID-19 pandemic and the subsequent shutdown in cancer services will lead to thousands of additional deaths and tens of thousands of life years lost. This is according to new modeling studies from the UK published in The Lancet Oncology. When the UK-wide lockdown to combat the COVID-19 pandemic was implemented on March 23, 2020, cancer screening and routine outpatient referrals in the NHS were suspended, and treatment of cancer patients either halted or slowed down. Dr. Ajay Agrawal and his colleagues conducted a population-based modeling study to estimate the potential impact that the pandemic has had on cancer deaths. They collected data on more than 32,000 patients with breast cancer, 25,000 with colorectal cancer, 6,700 with esophageal cancer, and 29,000 with lung cancer. Patients were diagnosed between 2010 and 2012 and were followed until 2015. The investigators used that data to estimate the impact of diagnostic delays resulting from 12 months of physical distancing. For breast cancer, this would lead to about an 8% increase in the number of cancer deaths within 5 years of diagnosis, or between 281 and 344 additional deaths. For colorectal cancer, this would be about 16% increase in mortality over 5 years, with about 1,400 to 1,500 additional deaths. For lung cancer, there would be about a 5% increase in mortality, or about 1,200 to 1,400 additional deaths. And for esophageal cancer, the mortality increase over 5 years would be about 6% and would include between 330 and about 350 additional deaths. Across the 4 tumor types, between 59,000 and 64,000 life years would be lost because of physical distancing compared to the pre-pandemic era. In the second study, also published in the Lancet Oncology, Claire Turnbull and her colleagues obtained age and stage stratified 10-year cancer survival estimates for patients in England who were diagnosed with 20 common tumor types between 2008 and 2017. They also gathered data on cancer diagnoses made via urgent 2-week referrals between 2013 and 2016. Dr. Turnbull and her colleagues estimate that 6,200 patients were diagnosed with cancer of stages 1 through 3 per month. Of those diagnoses, 27% would die within 10 years of their diagnosis. They calculated that delays in 2-week referrals during a 3-month lockdown would lead to an average delay in presentation of 2 months per patient. A 25% backlog in referrals would lead to 181 additional lives and 3,300 life years lost. With a 75% backlog in referrals, an additional 276 lives and more than 5,000 life years would be lost. For a 75% backlog in referrals, the additional lives lost would rise to more than 1,200, and the number of life years lost would reach more than 22,000. And that's it for this episode of Blood and Cancer. Remember, you can find the source material and the original articles in the show notes.